This recorded lecture will be going over Chapter 30, Care of Patients with Disorders of the Gallbladder, Liver, and Pancreas. Cholelithiasis is the presence of gallstones within the gallbladder or in the biliary tract. The stones can vary in size from small gravel to stones as large as golf balls. When stones lodge in the common bile duct, the patient then has cholecystolithiasis. Cholelithiasis is more likely to occur in people with a sedentary lifestyle, those with a familial tendency, diabetes mellitus, and obesity. Cholesterol-lowering drugs will increase the amount of cholesterol secreted in bile. This cholesterol secretion can increase the risk of gallstones. Hemolytic disease, extensive resection of the bowel to treat Crohn's disease, bariatric surgery, rapid weight loss, multiple pregnancies, and the use of oral contraceptives or hormone replacement therapy will also increase the risk for gallstones. Cholecystitis is an inflammation of the gallbladder and is associated with gallstones in 90 to 95% of occurrences. Other causes will include obstructive tumors of the biliary tract and severely stressful situations like cardiac surgery, severe burns, or multiple trauma. Cholelithiasis will develop when the balance between cholesterol, bile salts, and calcium in the bile is altered to the point that these substances precipitate. The formation of stones within the gallbladder can cause irritation and areas of inflammation in the gallbladder wall. Symptoms will depend on the degree of obstruction to bile flow and the extent of inflammation of the gallbladder. The absence of bile in the intestine results in clay-colored stools that float due to the undigested fat content. Severe pain can be triggered by a fatty meal. Nausea, vomiting, fever, and leukocytosis will all occur with cholecystitis. The pain could be referred to the right clavicle, scapula, or shoulder. As bile backs up into the liver and blood, jaundice, which is a yellow tint to the skin and sclera, will occur. If the obstruction is unrelieved, inflammation will occur and can progress to liver damage. The symptom most often present in an acute flare-up of chronic cholecystitis is unbearable upper right quadrant pain. This is known as biliary colic. These attacks can occur as frequently as daily, or they could appear just once every year or so. If the inflammation is not corrected, or if there is an infection, the gallbladder can become filled with pus and then rupture. Rupture will spill gallbladder contents into the abdominal cavity and cause peritonitis. Chronic cholecystitis will cause milder symptoms between acute attacks. The symptoms can include indigestion after eating fatty foods, flatulence, nausea after eating, and some discomfort in the right upper quadrant. Gallstones can usually be diagnosed with ultrasonography or a CT of the gallbladder and biliary tract. Cholecystography, or a hepatic immunodactic acid or HIDA scan, will diagnose abnormal contraction of the gallbladder or obstruction. An alanine aminotransferase, or ALT, and an aspartate aminotransferase, or AST level will be slightly elevated. In biliary obstruction, both the direct bilirubin and alkaline phosphatase levels will be elevated. Initially, a low-fat diet, loss of excessive body weight, and restriction of alcohol intake are recommended. Meals should be spaced so that no large amounts of food are put into the intestinal tract at any one time. Medical treatment includes giving oral medications that dissolve the gallstones. Endoscopic retrograde cholangiopancreatography, or an ERCP, can be performed to remove these stones obstructing the common bile duct. This procedure will combine endoscopy with fluoroscopy to visualize and treat obstructions. Antibiotics are usually only given if peritonitis is present or as surgical prophylaxis. The surgical procedure of choice is a cholecystectomy, which is a gallbladder removal. In the United States, 90% of cholecystectomies are performed laparoscopically. You should monitor the patient closely for any internal bleeding and watch for signs of increasing abdominal rigidity and pain, as well as changes in vital signs. On page 717 in the blue patient teaching box, you can read about care after a laparoscopic cholecystectomy. Although the laparoscopic approach is the common surgical technique, an open cholecystectomy will sometimes be indicated. With an open abdominal cholecystectomy, a 2 to 4 day stay in the hospital is typical, and there will be about a 6-week recovery period. Oral dissolution therapy is available, and it works best on small cholesterol stones. Ursodiol and Chenodiol are prescribed for 6 months to 2 years to dissolve the stones. There is a high incidence of reoccurrence. Lithotripsy or shockwave therapy is rarely used for gallstones. The treatment of choice is gallbladder removal. If nausea cannot be controlled with medication, an NG tube can be placed to reduce the vomiting. Coagulation time should be monitored if jaundice is present, and vitamin K, if needed, based on the INR, will be administered prior to surgery to improve clotting ability of the blood. Postoperatively, the patient should be placed in the semi-Fowler position. The carbon dioxide instilled in the abdominal cavity during a laparoscopic procedure will cause sensation of abdominal distension and shoulder pain. The gas is not actually within the GI tract, so it can't be expelled as flatulence. Instead, it will dissipate over time, and ambulation can assist with the process. A patient who has had open gallbladder surgery may have tubes or drains if any continuing drainage is expected. This drain will be left in place for as long as necessary and then removed by the surgeon. One of the drains that could be inserted is a small T-shaped tube or a T-tube. It'll be placed directly into the common bile duct during an open cholecystectomy. This tube must be kept patent at all times, and it will be connected to a small drainage bag or bile bag. The patient should be prepared to expect a greenish-yellow discharge. This is the bile on the dressings. Patients could go home with their T-tube in place. On page 718 in the blue patient teaching box, you can read about caring for a T-tube. You should carefully observe the color of the patient's stools because a return of normal brown-colored stool is an indication that bile is flowing and entering the small intestine. Encourage exercises with an incentive spirometer and auscultate lung sounds every shift to discover any signs of extra secretions or atelectasis. No specific diet will be recommended for patients after gallbladder surgery, although it is wise to avoid excessive amounts of fatty foods. Complications: a fistula could form. Necrosis, gangrene, and rupture of the gallbladder causing peritonitis could occur. Pancreatitis is another possibility. Disruption of the normal functions of the liver can occur depending on how much of the liver tissue is affected. This picture can be seen on page 718. There are 5 types of viral hepatitis that will cause physical problems. Hepatitis viruses cause extensive inflammation of the liver tissue. On page 719 within table 30.2, you can read and compare the hepatitis-causing viruses. Liver cells do have the capacity to regenerate and resume their normal appearance. There is a good mnemonic to remember your hepatitis types. Think hepatitis A for apple, hepatitis B for blood, hepatitis C for chronic, hepatitis D goes with B, and hepatitis E is environment. Hepatitis A and E viruses are transmitted primarily by the oral fecal route, hence apple. Hepatitis A can be transmitted by food handlers to customers or by mollusk shellfish from contaminated waters. Hepatitis E virus infection will primarily be seen in less developed countries. It'll be transmitted through fecal contamination of water, hence E, the environment. Hepatitis B, C, and D viruses can all cause chronic inflammation and necrosis of liver tissue. Asymptomatic individuals can transmit the infection to others. Hepatitis B and C viruses are transmitted by the parenteral route as well as sexually. They are present in semen, vaginal secretions, and the saliva of carriers. Sexual partners of patients who are carriers of hepatitis B or C virus are at a high risk for contracting this virus. Hence, B for blood. Hepatitis D virus will coexist with hepatitis B or C virus, and it will be transmitted in the same ways. Hence, D goes with B. Intravenous drug use is currently the primary cause of hepatitis C infection. Therefore, users are a target group for screening and counseling. This virus can also be transmitted by straws used to snort cocaine. Since 1992, all blood products have been tested for blood-borne pathogens. Patients who received blood transfusions and clotting factors before that time may have been exposed and could be carriers. Hepatitis B and C are the most serious forms of hepatitis, often progressing to chronic hepatitis, cirrhosis, liver cancer, and death. Hence, C for chronic. The clinical signs and symptoms of hepatitis A tend to have an acute onset, whereas in hepatitis B, C, and D, the onset will be slower and more difficult to identify. There are 4 phases of hepatitis A. The first phase is the viral replication phase, in which individuals will have a positive blood test but display no symptoms. The second is the prodromal phase, in which symptoms like nausea and fatigue are likely to be diagnosed as the influenza begins. The third phase, or the icteric phase, is characterized by jaundice and can last 2 to 4 weeks. The urine will become dark, and stools could become light if the bile flow is obstructed. The liver will become tender and enlarged. In the fourth and final phase, the convalescent phase, this begins when the jaundice is disappearing. Convalescence can take 2 to 4 months. With chronic hepatitis B and C, patients are likely to be asymptomatic or have symptoms of chronic liver disease. Symptoms could include fatigue, nausea, vomiting, poor appetite, right upper quadrant pain, dark urine, and light-colored stools. Hepatitis D sometimes causes massive destruction of liver cells, liver failure, and death. Hepatitis B and D become chronic in 2 to 10% of infected patients. The patient will then be a constant carrier of the virus. Hepatitis is diagnosed by history, physical examination, and laboratory testing. Chronic hepatitis will be determined by liver biopsy. Elevations in liver function tests, also known as LFTs, are expected findings. On page 721 in the blue table 30.3, you can see some laboratory test findings in acute viral hepatitis. Hepatitis A will be treated by rest and avoidance of any substances, including alcohol, that could lead to liver damage. A well-balanced diet will help the liver cells heal. Vaccines are available for those at risk to exposure. For hepatitis B, drug therapy will be used to decrease the viral load, therefore decreasing disease progression. Antiviral medications have been used successfully in the treatment and cure of active hepatitis C. On page 721 within table 30.4, you can see some drugs commonly used to treat liver disorders. Hydration, sufficient rest, and adequate nutrition are the goals. Medication for nausea could be prescribed to encourage adequate nutrition. Vaccines are available to provide active immunity against hepatitis A and B. Passive immunity to hepatitis A can be conferred by the administration of immune globulin, or IG. IG is also recommended for those who have been exposed to someone infected with Hep B virus who was not immunized against the virus. There is no protective vaccine for the hepatitis C virus. Data collection for a patient with hepatitis should include a nursing history of any previous contacts and whether those contacts have been notified or immunized. By law, viral hepatitis must be reported to the State Department of Public Health. Because the liver detoxifies many chemicals and metabolizes certain drugs, a complete list of recently taken or current medications is essential. It may be necessary to discontinue some drugs that are particularly toxic to the liver. Mental confusion and coma associated with hepatic encephalopathy can occur due to the circulating toxins that result from liver failure. Encephalopathy is a malfunction or disease of the brain. Nursing interventions will include reviewing trends of serum liver enzyme levels, as well as serum bilirubin values. Preventing the spread of infection is a major concern whenever caring for patients with viral hepatitis. This will include proper handling of body secretions, proper hand hygiene, and limiting contact with others. Sedatives must be given with caution due to a diseased liver cannot detoxify them well. Alcohol should be avoided. Both the feces and the blood of patients with hepatitis A will contain the virus during the initial prodromal stage. These patients are infected, but they are asymptomatic. Consistent use of standard precautions can provide protection for healthcare personnel. The patient and family should also use these precautions at home. Hepatitis B and D viruses are rarely transmitted by the fecal-oral route, but it is strongly recommended to be very careful when disposing of a patient's stool. Standard precaution guidelines must be carefully followed for handling, sterilizing, and disposing of equipment contaminated with blood. Hepatitis viruses are transmitted by sexual contact, so the patient must also be educated on that. Hepatitis is on the Center for Disease Control and Prevention's National Notifiable Conditions list, and facilities and healthcare providers are required to report cases. Infection with hepatitis A in a person who handles food on the job must be reported promptly. A small percentage of patients with hepatitis can develop massive necrosis of liver cells that will result in acute liver failure. The only hope for recovery is a liver transplant, and without transplant, death will occur in about 75% of these cases. Hepatitis B and C, alcoholic liver disease, and non-alcoholic fatty liver disease are the leading causes of cirrhosis. Other less common disorders that can alter liver function include biliary cirrhosis, which will result from chronic biliary obstruction and infection, and cardiac cirrhosis, which results from long-standing severe right-sided heart failure in patients with cor pulmonale. Whatever the cause, in cirrhosis, the liver cells are damaged, causing altered function, blood flow, and structure. Cirrhosis is a progressive, chronic disease of the liver. Normal hepatic structures are destroyed and then replaced with fibrotic tissue. Late cirrhosis is considered irreversible. When liver cells begin to degenerate, the blood vessels within the liver will fail to function. This causes obstruction to the flow of blood through the portal circulatory system, leading to portal systemic hypertension. The damaged liver has a limited ability to synthesize albumin, and this change in osmolality will allow fluid to leak out of the vessels into the tissues, contributing to edema and providing more ascites fluid. Cirrhosis usually progresses without symptoms until severe liver damage is present. Subjective symptoms of liver cirrhosis include fatigue, weakness, headache, anorexia, indigestion, abdominal pain, nausea, and vomiting, as well as ascites and weight gain. Dyspnea can also occur. Objective symptoms of liver cirrhosis would include excessive gas, skin rashes, and fever. Leg and foot edema, as well as palmar erythema, which is redness of the palms that will blanch with pressure, can occur. Sometimes bluish varicose veins, called caput medosa, will radiate from the umbilicus. This will indicate portal hypertension. Bleeding and bruising will occur due to deficiencies in vitamin K, thrombin, or prothrombin that are interfering with clot formation. Skin lesions, jaundice, pruritus, bleeding disorders, endocrine disorders, and peripheral neuropathy can occur in late disease. Spider angiomas, which are an abnormal collection of blood vessels under the skin, can appear on the face, neck, upper trunk, and arms. Urine may become dark and foamy, and stools will turn clay-colored, indicating that bile is not reaching the intestine. Jaundice occurs. Excessively high levels of bile pigment, or bilirubin, will be present in the blood. The pigment is deposited in the skin, mucous membranes, and body fluids, leading to a change in color ranging from pale yellow to golden orange. The first signs of jaundice will typically be seen in the sclera of the eye. This is known as icterus. Jaundice is not always a sign of liver damage. In hemolytic jaundice, there may be an increased level of bilirubin as a result of excessive destruction of red blood cells, with a resultant release of the pigment into the bloodstream. Elevations in liver enzymes typically do not occur until 65% of liver function is gone. This picture can be seen on page 730. A definitive diagnosis of cirrhosis of the liver can be made by liver biopsy. CT and liver ultrasound can also help determine this diagnosis. They can outline the hepatic blood flow and any vascular obstruction. Magnetic resonance cholangiopancreatography, similar to an ERCP but without the use of any invasive procedure, could also be performed. Treatment will be aimed at stopping liver damage, preventing further damage, and managing the symptoms. Identifying and removing the cause of liver damage when possible is the primary treatment. Treating hepatitis, abstaining from alcohol intake, and managing diseases contributing to liver damage will stop the progression of the condition. Medical treatment of ascites includes restriction of fluid and sodium intake, as well as the administration of diuretics. An abdominal paracentesis, which is the removal of ascites fluid, could also be performed to remove the accumulated fluid. However, this is a temporary measure and it does pose problems of rapid fluid shift, loss of protein, and the potential for introducing infectious organisms into the peritoneum. A transjugular intrahepatic portosystemic shunt, or TIPS procedure, can be used to decrease pressure between portal and hepatic veins in the liver, as well as to decompress varices. TIPS is performed to decrease risk of bleeding due to the esophageal varices and can reduce accumulation of ascites. On page 730, see the red safety alert box. Patients with liver inflammation or cirrhosis should avoid taking large doses of vitamins and minerals. This would include vitamin A, iron, and copper, which can worsen liver damage. The current recommendation is to manage encephalopathy with medications rather than to restrict protein. Calorie and protein requirements are increased with cirrhosis, and most patients with liver disease are malnourished. Lactulose, an exchange resin, can be given orally or by a feeding tube to induce diarrhea and prevent diffusion of the ammonia out of the intestinal tract. Ammonia, which is a known neurotoxin, has been believed to be the origin of hepatic encephalopathy. Kidney failure will sometimes accompany liver failure, and this is called hepatorenal syndrome. Assess your patient for any safety issues related to a change in mental status. Pay extra attention to ammonia levels, albumin, AST, ALT, and the PT and INR results. Daily weight checks should also be initiated if fluid retention is observed. If alcoholism is an issue, be vigilant for any signs of withdrawal, which can occur 6 to 12 hours after the last drink and then can continue for 3 to 5 days. Be sure to get an order for the implementation of the alcohol withdrawal protocol when indicated. The intake of alcohol and administration of drugs toxic to the liver should be completely restricted. The degree of rest and activity will be dictated by the stage of the illness. The patient is at a great risk for infection, and they should be protected from exposure to infectious agents. Antibiotics should be given quickly whenever infection occurs. Bleeding from esophageal varices, which are dilated, distorted, and gorged veins, is a major complication of cirrhosis. They are the result of portal congestion and hypertension. When the vein walls rupture, bleeding will occur. The liver is no longer able to make vitamin K, an essential component of clotting, so this bleeding can be substantial. These varices can rupture and produce hematemesis. This is the vomiting of bright red blood due to increased blood pressure, coughing, vomiting, or mechanical irritation from poorly chewed food. More than 90% of patients with cirrhosis will have esophageal varices, and 30% of those will bleed. Treatment options include the administration of parenteral vasopressors, like vasopressin, to lower portal pressure, the injection of scleropathy, or ligation of the bleeding vessels. A beta blocker can be given to lower blood pressure. The patient will be given vitamin K to help rectify their clotting factor deficiencies. Portal systemic encephalopathy or hepatic encephalopathy is another dangerous complication of cirrhosis. Symptoms include delirium, convulsions, asterix, which is flapping tremors, and coma could occur. Asterix is identified by having the patient hold out their arms and hands and observing for any rapid flexing and extension movements of the hands. Fetor hepaticus, which is the breath taking on a sweet fecal odor, will occur as liver failure progresses. This image can be seen on page 731. Liver transplantation will be considered for patients with progressive and advanced liver disease that does not respond to treatment. It is mostly commonly done for non-alcoholic cirrhosis, chronic active hepatitis, sclerosing cholangitis, metabolic disorders, and biliary atresia in children. Between 70 to 80% of liver transplant recipients will survive at least 3 years with a good quality of life. Every attempt should be made to keep the ICP within normal limits, due to the increased ICP levels being correlated with lower survival rates after transplantation. After surgery, a T-tube and bulb reservoir drains could be in place. An NG tube will stay in place until bowel function resumes. The patient must then take cyclosporin for life to prevent the rejection of the new liver. Measures will be instituted to prevent pneumonia, atelectasis, and pleural effusions. Right quadrant or flank pain, increasing jaundice, fever, and changes in stool and urine color can all indicate organ rejection. Primary cancer of the liver is rare in the United States, but it is a common malignancy in Africa and Asia, where it can then be caused by a parasite called the liver fluke. Metastatic liver cancer is much more prevalent than primary liver cancer, but the end result will be the same. Cirrhosis and hepatitis B or C will increase this risk. 3 times as many men as women develop liver cancer. There are 2 types of primary liver cancer: hepatoma, which arises from the hepatocytes, and cholangiocarcinoma, or bile duct cancer. It can both metastasize to the lungs, brain, kidneys, and spleen. Symptoms will include right upper quadrant pain, fatigue, anorexia, weight loss, weakness, or fever, plus signs of poor liver function. Because symptoms are often vague, diagnosis of liver cancer can occur late, and then death will occur within 6 to 18 months. CT or MRI can be used to determine the presence of the tumor, as well as the stage of the cancer, and find any areas of metastasis. If no distant spread has been found and there is no lymph node involvement, surgical resection can be attempted. If the tumor is primary and has not metastasized, liver transplantation is an option. Treatment will be combined radiation and chemotherapy that is infused intravenously or directly into hepatic circulation. Several medications that shrink the tumors or halt their progression are available. Other drugs that inhibit tumor growth by interfering with the blood supply that feeds the tumor can be given in combination as well as singly. Tumor ablation can be used for tumors less than 5 centimeters in diameter. Laser or radiofrequency ablation using heat to destroy cancer cells can be performed with a local anesthetic. Nursing care will include assessing for signs and symptoms of liver failure, as well as blockage in the common bile duct. Additional care will be directed at the associated problems, like ascites and encephalopathy. Surgical care will be provided as for any other abdominal surgery patient. Pancreatitis is an inflammation of the pancreas. It can be acute or chronic. Most cases of pancreatitis are related to gallstones blocking the common bile duct. Viral infections, trauma, ERCP, penetrating ulcers, drug toxicities, metabolic disorders, scorpion stings, and a variety of other factors can all cause pancreatitis. In some types of pancreatitis, the severe inflammation and damage are caused by the escape of pancreatic digestive enzymes. Pancreatic abscess or pseudocyst can develop. A pseudocyst is a sac-like structure that forms on or around the pancreas. Pancreatitis will cause abdominal pain that is typically acute, but this can vary among individuals. The pain will be steady and localized to the epigastrum or the left upper quadrant. Sitting and leaning forward could ease this pain, and the severity of the pain can slowly decrease after 24 hours. Eating will make this pain worse. Nausea, vomiting, sweating, jaundice, and weakness will often accompany the pain. Examination of the abdomen will reveal tenderness and guarding. If retroperitoneal bleeding is present, there can be bruising in the flanks or a bluish discoloration around the umbilicus. Serum amylase could be 2 times normal, and it will remain elevated for 72 hours. Serum lipase will remain elevated for several days. Laboratory values could indicate hypoglycemia, hypocalcemia, and hypokalemia. Diagnosis will be based on symptoms, risk factors, and results of tests performed to rule out other disorders. An abdominal ultrasound, CT scan, and serum and urine amylase studies are usually ordered. Diagnosis is made when a patient presents with 2 of the following: an acute onset of severe epigastric pain, lipase or amylase that is elevated 3 times the normal level, and a CT, MRI, or ultrasound finding consistent with pancreatitis. And this concept map can be seen on page 736. Pain evaluation and control are primary nursing responsibilities. Observe for any signs of restlessness, the use of accessory muscles for breathing, irritability, confusion, or dyspnea, which all could indicate respiratory distress. You should administer oxygen as ordered. Administer fluids and observe for any electrolyte imbalances. Within 48 hours of admission, enteral feeding can be implemented via an NG tube if the patient is unable to take in adequate nutrition. As soon as tolerated, oral feeding with a low-fat solid diet can be provided. If abscess or pseudocysts are present, they can be surgically drained. IV hydromorphone or morphine via a PCA pump may be needed to control the pain. Histamine H2 receptor antagonist or a proton pump inhibitor can be given to decrease the hydrochloric acid secretions that stimulate pancreatic activity. Administration of antispasmodics like dicyclomine or propanthyline bromide can be helpful. Alcohol abuse will account for half of the chronic pancreatitis cases in men. Abdominal pain is the major symptom. There may be periods of acute pain, but consistent chronic pain is more common. Nausea and vomiting could also be chronic. Other symptoms related to pancreatic insufficiency, as less and less pancreatic tissue is functional, will occur. Malabsorption with weight loss and steatorrhea, constipation, mild jaundice with dark urine, and diabetes mellitus will develop. Determination of bicarbonate, protease, amylase, and lipase concentration, as well as output in the duodenum after stimulation with secretin, will be a helpful test for chronic pancreatitis. An MRCP or ultrasound could also be performed. Pancreatic cancer or a liver disorder can produce the same results on these tests. Therefore, differential diagnosis will be difficult. Advanced disease can be best identified with CT scan. Treatment during an acute episode of chronic pancreatitis will be the same for acute pancreatitis. Eliminating alcohol intake is essential. Small, low-fat meals and good hydration have helped some patients. Amitriptyline and nortriptyline can help the neuropathic pain component. NSAIDs can also help. Chronic pancreatitis interferes with the patient's usual lifestyle and is often accompanied by depression. Therefore, your patient should be periodically assessed for any signs of depression, and any appropriate referral should be made. A major nursing action is to be supportive of efforts to abstain from alcohol. The cause of pancreatic cancer is unknown. It is more common in men than in women, and it occurs more often in people older than 55 years. Cancer of the pancreas is often fatal within 1 year. It is usually in an advanced state when discovered due to its asymptomatic condition in early stages. Cigarette smoking is the major risk factor for pancreatic cancer. 2 to 3 of every 10 cases are linked to tobacco use. Obesity and dietary factors will also contribute to pancreatic cancer. Metastasis will typically occur early. Epigastric pain and weight loss are the main symptoms of pancreatic cancer. Anorexia and vomiting could occur, and the patient may develop a dislike for red meat. There will also be a glucose intolerance. Diagnosis can be made by ultrasonography, imaging techniques, and a fine needle biopsy. High doses of opioid analgesics are typically required to keep the patient comfortable. Drug dependency should not be a concern. Treating or preventing malnutrition is a major goal. Enteral feedings may be needed to be given into the jejunum. This is called a jejunostomy. Surgical treatment is appropriate for any resectable tumors. This occurs in about 50 to 20% of patients, but it is not highly successful in curing the disease. Surgery will be used mainly to relieve symptoms of obstructive jaundice, severe pain, or other complications. A Whipple procedure or radical pancreaduodenectomy could be done for cancer of the head of the pancreas. Other treatments will include radiofrequency ablation and microwave therapy, which both use heat to destroy the tissue, as well as cryosurgery, which uses cold. Chemoradiotherapy could also be used. Gemcitabine and 5-fluorouracil are common for treatment for non-resectable or metastatic tumors. Other drugs that could be used would include targeted therapy drug sunitinib, which blocks the growth signal, and octreotide, as well as lanreotide, both which suppress the hormone release from the tumor. Nursing care will be geared toward managing the severe pain and managing side effects of treatment. Postoperative care will be similar to that of any patient who has had abdominal surgery. Nurses in the community should promote immunization against hepatitis B virus in all persons at risk. Teenagers and adults should be counseled about the possibility of transmission of hepatitis B virus by sexual contact and advised for measures for protection. Nurses should be aware of policies and procedures for reporting any new cases of hepatitis to the local health department. Nurses in extended care facilities should be alert to signs of jaundice in patients. Home care nurses must be particularly alert to the possibility of liver or pancreatic problems caused by any medications the patient is taking.